All good. Okay, so we'll give it a couple of minutes. No, we've got some people joining. So thank you very much for attending our second lecture in the medical legal teaching series of Mind the Bleep. So yeah, my name's Alvin. I'm the medical legal lead at Mind the Bleep. That's a free education platform for doctors, medical students, and sort of healthcare professionals worldwide. And so as part of it, we're running a 9-part medical legal series covering various aspects of the, well, medical legal aspects that are pertinent to working within the NHS. So just as a couple of ground rules actually before we start. So this works as a YouTube live, so any comments that you want to ask us or questions that you have for our speaker today, please post them in the chat on the right-hand side. And so certificates as well, they'll be generated at the end. We'll be posting a QR code that you can complete, and that will generate your certificate for today. So please sit tight until the end. And as a sort of generic disclaimer that we need to give for all of these medical legal lectures is that everything that will be talked about today is up to date as of now. So yeah, I think that's pretty much, it. So without further ado, we're very thankful to have Dr. Aditi Ranjan, who's going to be giving a talk today on prescribing. So please, Aditi, after you.
Thank you very much for the introduction, Alvin. So I'll just introduce myself briefly. So my name is Aditi. I am an academic teaching fellow, but also a trust grade doctor. So I'll be giving this session on prescribing. So what I'll start doing is I'll start sharing my screen, and then we can get started.
Please let us know if you have any issues seeing the screen or hearing as well.
Yeah. So, is my screen visible with my presentation? Is that all right, Alvin? Can you see my presentation?
Yeah, it seems to look good from my perspective.
Fabulous. In that case, yeah, I'll get started. So, as I mentioned, I'll be doing this session around prescribing and the medical legal aspects of this. So, just to go over the things we'll be covering briefly. So, I'll start off by talking about the duties of a prescriber. Following that, I will talk about some special scenarios for prescribing. So this includes unlicensed medications, off-label medications, and what to do if you're in a scenario where you're being asked to prescribe for someone you have a close relationship with, such as friends or family. And then finally, I'll go on to talking about errors, duty of candor, and the GMC guidance that surrounds all of this. So I know we had a disclaimer earlier, but another disclaimer that I'm not a medical legal expert and I'm not a GMC representative. So all of this information is to the best of my knowledge from my own research and my own learning. I'm happy to take questions either as we go along or at the end. And I'd like for the session to be interactive as well. So there are some points where I will be asking questions. So please feel free to post things into the chat, and I'm happy to look at those. Cool. So let's get started. So I think a good place to start would be looking at the key legal frameworks that govern prescribing in the UK. And I think that having an understanding of this background is good for the understanding the medico legal responsibilities we carry as prescribers as well. So there are four major frameworks we need to be familiar with. So the first is the Medicines Act 1968. So this defines what constitutes as a medicine, and it sets out the legal requirements for supply, for possession, and the use of medicinal products. And it also outlines who is legally allowed to prescribe and under what conditions. So essentially, this act provides a legal boundary within which we need to operate when prescribing. The second one is the Misuse of Drugs Regulation 2001. So these regulations focus on controlled drugs. So this is the Schedule 1 all the way through to Schedule 5 substances. And as prescribers, it's quite vital to have an understanding of these categories, as depending on where you work, you might be prescribing Schedule 2 or Schedule 3 drugs. But I'll talk about the legal aspects of these prescribing these later on in the presentation. The fourth one I wanted to talk about, third one, sorry, I wanted to talk about was the General Medical Council, so the GMC's guidance for good medical practice. So this isn't a legal framework or a legislation per se, but it is a professional standard that holds weight in practice. So it outlines the ethical and also the professional duties of a doctor when it comes to prescribing. And it emphasizes the importance of things such as patient safety, informed consent, evidence-based practice, and effective communication with patients. So non-compliance with this guidance can lead to disciplinary action with the GMC, so it's important to be familiar with the GMC guidance that surrounds prescribing. And the final one I wanted to talk about was the Humans Medicines Regulation 2012. So these regulations consolidate aspects such as the licensing, labeling, storage, and prescribing and dispensing protocols. So now that we've had a look at the legal frameworks, I want to move on to some of the practical responsibilities. So these core duties aren't just best practice, they are some of them are legal and some of them are ethical requirements. And failure to meet some of these can possibly result in disciplinary action or civil or criminal proceedings. So, breaking them down a bit further, so the first one I wanted to talk about was ensuring safe and effective prescribing. And this basically involves having a good understanding of what's being prescribed. So, being aware of a drug's indications, but also contraindications, side effects, and interactions. And one of the way that we can facilitate this is through the use of the BNF, which is the go-to reference. And it can just help us ensure that we're using the right drug at the right dose for the right indication. When it comes to making prescribing decisions, it is important that we make sure that the patient also understands the treatment, the purpose, risks, benefits, and any alternatives as well. So, informed consent is a key part of helping with patient autonomy. And prescribing isn't just a one off event. So, we need to regularly review all the prescriptions, making sure they're appropriate, whether the patients are having any side effects. And finally, record keeping and accurate documentation is quite essential about what was prescribed, the dosage, and any discussions around consent. And good records are beneficial for both patient but also the prescriber as well. So now I'll go on to talking about some of the special scenarios that I mentioned earlier. So I will start with a topic that often causes a lot of confusion. So this is the difference between off-label and unlicensed prescribing. So whilst these two terms are used interchangeably, they aren't the same, and this distinction has important medico legal implications. So, starting off with off-label use. So off-label uses of medications are licensed medications, but they are being used in a different way to their license. So this could mean that a drug is being used for a condition that it's not approved to treat, or for a different dose, or via an alternative route of administration, or even for a different population, such as for children or for pregnant individuals, where the drug hasn't been explicitly authorized. So, off label prescribing is acceptable, but only under specific conditions, such as if the benefits outweigh the risks. And it's often found in places such as pediatrics, where it's often difficult to develop age appropriate formulations, but also for palliative care and for rare diseases as well. So in these cases, it's the responsibility of the prescriber to justify their decision and then to document it thoroughly as well. Now, going on to unlicensed medications, so these are drugs that don't have UK marketing authorization by the MHRA. So it could be that these medications are licensed abroad, for example, or they are only specially manufactured formulations or they're new medications. So the most common example that we come across is liquid formulations of medicines that only have a license in the tablet form. So unlicensed prescribing, like off-label prescribing, is also legal. But again, there needs to be a solid clinical rationale, which is backed by evidence and established guidelines. But in both cases, the duty of the prescriber is the same in terms of acting with the patient's best interests, to ensure informed consent, and to keep accurate documentation. So just to summarize, so unlicensed medications are medications that don't have a license, they haven't been approved by a regulator, whereas off-label medications have a license, they're just used outside of their terms that are on the license. So I'll start off with a case scenario. So a patient has moved to the UK from abroad. They attend your GP practice and they are requesting repeat prescription of their regular medication for depression, which they've been taking for the last 2 years. You get the medication history, and it says that they take escitalopram 40 milligrams. So, keeping in line with the core duties of prescriber, you go onto the BNF, you look up escitalopram, and for an adult by mouth, you see that it says 10 milligrams once daily, if necessary, increased up to 20 milligrams once daily. So there is a mismatch between um, the amount that the BNF says we can go up to versus what the patient is already established on. So this raises some interesting questions. And it is a difficult situation. So I'm happy to open up the floor or the comment section rather. Um, so please feel free to type in the chat like any legal or ethical considerations that should be taken into account when prescribing off-label. So I'll give 20 more seconds for people to finish typing in the chat. Okay, so I'll start off by talking about some of the legal considerations. So first consideration is legality. So legally, off-label prescribing is permissible, but it comes with certain responsibilities. So the prescriber is accountable for the outcome, like even if things go wrong. So ethically, doctors have a duty to prioritize patient safety, to ensure that informed consent has been gained, and when working within the NHS to use treatments that are both effective but also economically justified. So this means that sometimes choosing the most cost-effective option, which also meets the patient's clinical need. In terms of when this off-label prescribing can be justified, so as I mentioned a bit earlier, it's when there's no suitable licensed alternative available, then we can consider off-label prescribing. But again, we need to look at clinical evidence, guidelines, and established practice. And crucially, we have to be confident that the medication is appropriate for that individual patient. And I think one of the important things to remember is just because a patient requests a certain treatment, it doesn't mean that the doctor is obligated to prescribe it. So clinicians should use their professional judgment when it comes to prescribing off label if they believe that it's the best option in that clinical context. Looking at the documentation that is required, so if you do decide to prescribe things off label, you must clearly document your rationale for doing so and why you've decided to go for an off label or an unlicensed medication, and how the licensed options weren't suitable, and how you're going to assess the risk and benefits, and then also document clearly the fact that you've got informed consent. Um, and the potential risks and benefits. So benefits involved, like off-label prescribing can increase access to effective treatments where licensed options don't exist. So this can be very useful in like pediatrics or rare diseases or oncology. But risks include adverse side effects, medical legal liability, um, and especially when the prescribing isn't that well supported. So overall, off-label prescribing can be appropriate, but only when it's been well communicated with the patient and evidence-based. But from the role of a foundation doctor, if you're ever in a situation where you're required or being asked to prescribe something that's off-label or unlicensed, I would highly advise you to discuss that decision with a senior colleague before you do so. Okay. So now moving on to the GMC's perspective on all of this. So they in this so this is pulled from the GMC's guidance for good medical practice. So it's the good practice in prescribing and managing medicines device content section. So um, with regards to this section, they used unlicensed medications to um, refer to anything that's either being used off-label or unlicensed. So it's a group, it's an umbrella term. And they basically say that the licensed medications, if they are licensed, should be used in accordance with their licenses wherever possible. But in certain situations, prescribing unlicensed medications is justified. They go on to talk about if there's no suitably licensed medication that meets the clinical needs, then it is appropriate, or if their normal licensed medication is temporarily unavailable. Sorry. As a part of a approved research study, you can also prescribe unlicensed medications. And also in the cases of public health emergencies, where the MHRA has temporarily authorized unlicensed treatments, such as during a pandemic. So, when prescribing unlicensed medications, the GMC outlines that there needs to be three critical responsibilities. First, you must be satisfied that there is sufficient evidence or clinical experience to demonstrate the medicine's safety and effectiveness. Secondly, you have to take on the responsibility for the prescription. So that involves overseeing the patient's care, ensuring that they are monitored appropriately, and arranging follow-up treatment. And if you are not personally able to take on ongoing responsibility, then you must make sure that there is another competent or an appropriate doctor who is able to do so. And thirdly, documentation is key. So it's your responsibility to have clear, accurate, and a legible record of everything that has happened, consent, but also your clinical reasoning. So the next section I wanted to talk about was guidance around conflicts of interest and prescribers. So doctors, first and foremost, shouldn't be or even appear to be influenced by any prescribing decisions by any form of financial incentives or personal gain. So this means that any decisions to prescribe medication should be based solely on the patient's clinical need and the evidence based. And even the perception of financial influence can undermine the public's trust and damage the doctor-patient relationship. And so the ABPI has produced a code of practice which governs the interactions between pharmaceutical companies and also healthcare professionals. And they have very clear restrictions on this. So, for example, doctors aren't permitted to accept gifts from pharmaceutical companies, and these companies can't provide branded promotional items to healthcare professionals. So this includes things such as pens, notepads, or any other merchandise that could subtly influence clinician behaviour. Um, the GMC and ABPI are very clear on this point, that patient care should come first and shouldn't be compromised in any way by any conflict of interest. And if this was to happen, this would be taken as professional misconduct. There is, however, one limited exception where hospitality can be accepted to attend educational meetings or events hosted by a pharmaceutical company, but only under specific conditions. So, for example, the hospitality event must be secondary to the educational content of the event, and it must be relevant to the professional role of the people who are attending. So, the third section I wanted to talk about in special prescribing scenarios would be prescribing for people who are close to you. So that includes friends and family. And this is an area where personal and professional boundaries can blur quite easily, and therefore it carries significant medico legal risk. So, breaking down some of the key issues. So, the first is a conflict of interest, but also the lack of objectivity. So, when treating a relative or a close friend, there can be a very clear conflict of interest. And as humans, we might be more inclined to favour someone emotionally and use this in other, as opposed to making an objective or a clinical decision. And this can compromise the impartiality that's required for safe prescribing. And there is a very clear GMC guideline on this, that prescribing for those close to you only happens under very specific exceptional circumstances, and doing prescribing outside of that without proper justification can result in investigations and fitness to practice proceedings. And the other important thing to remember is that when prescribing to relatives, it doesn't protect you legally. There is still risks of medication errors occurring, adverse events due to inappropriate prescribing, and you can still be liable for medical negligence, just as you would with any other regular patient. So, in summary, prescribing for friends and family should be avoided unless absolutely necessary. And if you're in doubt, you should always refer the patient to another appropriate healthcare professional. So, another case scenario. So you're a GP and you're approached by a close friend. She is experiencing symptoms of depression. She is reluctant to seek professional help, and she hasn't seen a doctor in several years. And you're concerned about her well-being. So it raises two key questions. What are the legal and ethical considerations? And secondly, what could you do? So I will give again 20 seconds in the chat for anyone who would like to volunteer an answer to volunteer an answer. Okay, so I can't see any comments so far, so I'll just talk about some of the legal and ethical considerations. So the first one is the conflict of interest that we mentioned earlier. So as a friend, your judgment could possibly be unintentionally biased, and this can affect clinical decision making, leading to a possible under treatment or a possible over treatment. The second would be professional boundaries should be considered in this situation. So this is very clearly blurring the line between your professional and your personal roles, and it can create a power imbalance and possibly place pressure on the relationship, especially if a treatment outcome doesn't go as planned. And the other main consideration is standard of care. So you have the duty to provide the same level of care to your friend as you would with any other patient. And that means full assessment, appropriate documentation, safety netting, follow up. And this can be hard to deliver informally or outside of a clinical setting. But the final other consideration would be the urgency of the care that's required. So, if your patient seems to have severe symptoms or she's in crisis, urgent care might be warranted. So, you should probably refer her to an appropriate service where she could get the care that she requires. So, what can you do in this situation? The best thing to do would be to encourage your friend to see another GP, someone who's neutral, who can assess her objectively, or refer her to the crisis team or another team as appropriate. You can offer emotional support as a friend, but from a clinical standpoint, any clinical care should be done by someone else. So, moving on to a second scenario. So, you're a GP living in a rural village in the Lake District. A close friend presents to you with central chest pain radiating down the left arm. It's central, it's crushing, they are sweaty, nauseated, very clearly unwell. And symptoms are very strongly suggestive of a cardiac event, potentially an ACS. So you've called for an ambulance immediately, and you're told that the nearest ambulance is unfortunately over an hour away because you live in a very rural location, and the nearest PCI, you know for a fact, is 2.5 hours away by ambulance. So, what could you do in this situation? So, again, I will give anyone who wants to post in the chat another 20 seconds, and then we can talk through the scenario as well. Okay, so under GMC guidance, this can be a potential emergency scenario. So you might be justified in prescribing for someone that you have a relationship with if you are the most accessible and the most appropriately trained clinician. But the criteria is very specific. So in this case, it would need to be a case where there is no other prescriber available. Delaying a treatment could pose a serious risk to life, and immediate treatment is likely necessary to either save life or prevent serious deterioration or alleviate uncontrolled pain. So, in such circumstances, it can be lawful and also ethical to act. So, you are allowed to initiate emergency treatment. For example, you can give your friend GTN and you can give them aspirin as well as clinically indicated, because you are the only prescriber available. However, the key thing in this scenario is that this is not regular prescribing for a friend, that you in this situation are providing emergency care where a failure to act could be detrimental to your friend's health. So after you provide emergency care and you stabilize the patient, once the emergency services do arrive, it's your responsibility to hand over appropriately, to clearly document everything that you've administered or prescribed. And ideally, you should inform your medical defense organization, especially given the personal relationship with the patient. So, in summary, there are situations where you can be justified in prescribing and treating if you are the most accessible clinician and you're in a situation where delay can cause harm, but this is an exception and it's not the norm. So, looking at the GMC's perspective on this about self prescribing and for prescribing for those um, with whom you have a close personal relationship, the GMC guidance is clear. Wherever possible, you must avoid prescribing for yourself or anyone that you have a close personal relationship with. So, this includes family members, partners, close friends, colleagues, especially when the clinical need isn't urgent or if another um, practitioner is available. So if you are in a situation where you have to prescribe for someone else, there are some strict conditions to follow. So you have to make a clear, accurate, and timely record of, ideally at the time of prescribing or as soon as possible thereafter, about the reason, the clinical justification, and the relationship with the person where relevant. And in doing all of this, it's important to follow GMC's broader guidance on information sharing, obtaining valid consent, and also safe prescribing practices. Um, so, in summary, avoid self-prescribing for those close to you wherever possible. But if it is unavoidable, needs to be documented clearly. You have to justify your actions, um, and follow all relevant prescribing standards. The next thing I wanted to talk about was paragraph 69 of the GMC's Good Practice in Prescribing, which is prescribing controlled drugs for either for yourself or for someone who is close to you. So, prescribing controlled drugs. So, when it comes to normal prescribing practices, this mainly includes Schedule 2 and Schedule 3 drugs. Um, and looking at the misuse of drugs regulation in 2001, the things that need to be included for a valid controlled drug prescription include things such as the patient's details, so full name, address, date of birth, which must be present, especially if the patient is a child under the age of 12, the date, because the prescriptions are only valid for 28 days after which they were uh, first issued, drug details, including name, strength, dose, form, so whether it's tablets, liquids, capsules, and the total quantity to be supplied in both words and figures. And it must be hand signed in indelible ink and also have your address as the prescriber and give an indication to your role, or the type of prescriber who's issued this. So, um, you can prescribe controlled drugs for yourself or for someone else if there is no other prescriber available, and again, as part of emergency treatment to avoid serious deterioration. But again, it must be life-threatening or clinically urgent, and it must be in a situation where there's no access to another clinician, and it is a professional misconduct to prescribe controlled drugs for those close to you on the regular. Okay. So I wanted to talk briefly about errors. So, unfortunately, errors are common when it comes to prescribing, and there are many different causes of errors. So it's often described as the Swiss cheese model, where there are lots of different things that can cause it. So the first one can be active failures. So it can be a mistake due to inadequate knowledge about either the drugs or the patient, but also uncommonly violations. Then you can have error-provoking conditions such as lack of training, lack of experience, fatigue, high workload. Um, and finally, you can also have latent conditions such as culture. For example, if you're working within a firm where there is a reluctance to question senior colleagues, there are defenses which are in place to prevent medication errors. So, the vast majority of drug errors are caught by either the nursing staff or pharmacists. But there can be situations, for example, weekend ward cover, where there might not be a ward pharmacist available after a certain time. And these can therefore allow things to go through the cheese model. And prescribing errors are often multifactorial. So, moving on to effective ways to reduce prescribing errors in modern medical practice is to use electronic prescribing systems. And the GMC recommend that electronic prescribing systems should be used wherever possible because they are designed to minimize human error by automatically checking for drug interactions, automatically flagging allergy warnings, and ensuring that correct dosages are prescribed. There's They also have a role to play with reducing errors due to illegible handwriting or transcription mistakes. So, electronic prescribing systems can be very helpful, especially in environments such as hospital or in complex polypharmacy cases. So, again, I will open this up to the floor. So, what is the prescription error rate by foundation doctors in England? So, I will give 15 seconds for everyone to consider. Okay, so it is 8.9%. So this comes from the Equip study. So this was a study that was done across 19 hospitals in England, where it was looking at error rates in prescriptions that were written. So there was an error rate of 8.4% for medications and prescriptions written by F1s, and 10.4% for prescriptions written by FY2 doctors. And taking the foundation cohort as a whole, this came out to an average of 8.9%. So, time for a bit of maths. So, assuming that a resident writes 30 prescriptions per day and works 22 days per month, how many prescriptions per month will contain errors? So, I will, again, about 15 seconds for this. Okay, so the correct answer is 59 prescriptions. So, assuming 30 prescriptions a day for 22 days per month, so that's about 660 prescriptions written over the space of a month, and calculating 8.9% of that will come out to 58 point something, and that's rounded up to 59. So, when it's put like that, it does make you realize what a high uh, rates of prescription errors you can get. And then this brings us on to the duty of candor. So the duty of candor is a critical medico legal responsibility for healthcare professionals. And at its core, it's about being open and honest when things go wrong with a patient's care. And this doesn't just involve communicating with the patient, but it also involves communicating with any relevant person acting on their behalf, such as a parent or a legal guardian or an LPA. And this isn't just a ethical duty, but it's also a legal requirement. So since 2014 Health and Social Care Act, there is a statutory duty of candor for healthcare providers in England. So practically speaking, this involves things such as if there are errors or something has gone wrong, informing the patient or someone acting on their a representative person about what has happened, providing support from both an emotional perspective, but also from a clinical perspective, and offering truthful explanations and sincere apologies. And this overlaps with other ethical duties such as informed consent. So patients should be given accurate information to make sure that they make um, choices about their care in a way that they would want to. So this uh, from this quote from the GMC is from the Openness and Honesty When Things Go Wrong, the Professional Duty of Candor document. And it highlights the professional obligation of all healthcare professionals about being honest with patients. And the professional duty of candor refers not only to the ethical responsibility to acknowledge mistakes or harm, but to communicate openly and also to take steps to put things right. So, point three, for example, explains that this isn't just about being open and honest with patients, but it's also about being open and honest with colleagues and employers. So this also involves things such as raising concerns and being transparent when it comes to incident reporting. So to summarize, I just wanted to cover some of the fundamental principles that underpin the legal and the ethical responsibilities of prescribers. So firstly, the doctor who signs the prescription bears both the clinical and legal responsibility for it. So this means that if you are writing a prescription, you're responsible for ensuring that it is safe, that it is appropriate, and it is in the patient's best interest, even if another clinician has recommended it. Secondly, you should only prescribe when you have sufficient knowledge about the medication, but also about the patient to be confident that it is suitable for that patient in particular. This involves indications, contraindications, and also monitoring requirements. And finally, you should avoid prescribing for those who are close to you, and wherever possible, avoid it as much as possible. And it's not acceptable to accept gifts or hospitality that could influence or appear to influence prescribing decisions. So, I think that's all from me. I'm happy to take any questions if there are any. And thank you all for listening. So I'll stop screen sharing.
Lovely, Aditi. Thank you so much for that lecture. We'll give another minute for people if they have any questions to post it in the YouTube chat. In the meantime, I'm going to post so you should see a QR code. Yeah, you can see it on my screen. Hopefully you can scan, let's see. If you scan the QR code, you'll be able to fill out the feedback form and then get your certificates as well. I'll also post a link for it in the chat. Just give me 1 second. I'll post it from the YouTube actually. But just so yeah, thank you very much for that. Very thorough, and you managed to squeeze in huge amounts in sort of the 45-minute period. I'm incredibly impressed by. Now, and once again, you do cover. What's quite sobering for that is all of these scenarios that you've mentioned, sort of prescribing for family, off-label and unlicensed products. I have experience, and I'm sure, Aditi, yourself, you have as well. So these are very pertinent issues for which you should know the legality behind. Especially, so a little thought from me is, especially the off-label and unlicensed, it's not you as a I'm suspecting that most people listening are juniors, but those often the scenarios in which you are prescribing those is when a consultant or a senior is asking you to. So you often don't know the justification yourself. Thus, it's even more important to document that clearly. So, and as you say, if you ever have an inkling that you don't know why you're prescribing something, ask your senior and get an explanation. Similarly with the family stuff, always document. In my mind, unless it's an emergency, always try and find another avenue. Or actually, you can even talk to your medical defense organization sometimes. Well, you can talk to your medical defense organization and ask them, is this an appropriate time to prescribe and so on? Unless it's an absolute emergency, they're always there to help.
Yeah,
And as
I
my
mean,
final
that is
point,
what they're there for as well.
yeah,
And
exactly.
and like you said about the off-label and unlicensed, like depending on which jobs you do, it's like you can end up doing a pediatrics job, for example, where you will need to, as you said, document all of these things clearly. And like this scenario that I used in the presentation is one from my own experiences. So I have been in a situation as a foundation doctor where I was, well, I went and asked one of my seniors.
Yes, well, there we go. And you've done the right thing there. And hopefully, this has been insightful for those of you who have watched. Once again, feedback QR code is just there on the screen. So if you have any time, otherwise, you can actually find it on the Mind the Bleep website as well. If you highlight the lecturer name, that's Aditi Ranjan, and the webinar name. Oh yeah, my final point was actually the prescription errors per month, very sobering and
Yes.
very real. So it's important to be mindful of that.
For sure.
Okay. Well, once again, thank you, Aditi, for your lecture. Thank you very much for your time.
Thank
And
you.
seeing as we have no further questions, um, I think we'll keep it at that. And just to remind all, this is a 9-part series, so if you keep an eye on the Mind the Bleep website, myself, Aditi, and Devesh will be giving further lectures on key medical legal principles.
Mhm.
Anyway, take care.
Right, thank you.
All right, bye.